Hi guys, welcome to another lecture in this series, Medicinal Chemistry 2, and today we're going to be talking about antiarrhythmic agents. So first we have to talk about what is cardiac arrhythmia. Well, they're caused by a disturbance in the conduction of the impulse through the myocardial tissue by disorders of impulse formation or by a combination of these factors. The antiarrhythmic agents used most commonly affect impulse conduction by altering conduction velocity and the duration of the refractory period of heart muscle tissue. They also depress spontaneous diastolic depolarization, causing a reduction of the automaticity by ectopic foci. Now, I know that some of these words may or may not be familiar, but as the presentation progresses, I am certain that some of these words will be defined further. So, just to look at this image here, which says abnormal electrical conduction due to ventricular ectopic foci. So what an ectopic foci is, the usual, this is the normal pacemaker of the heart. So this ectopic foci is actually an abnormal pacemaker site within the heart that display a similar automaticity, right, as a pacemaker. So, clearly if it is an abnormal pacemaker, then we would have some abnormal conduction pathways. All right, so let's talk about some of these pharmacological agents. So many pharmacological agents are available for the treatment of cardiac arrhythmias. Agents such as oxygen, potassium, sodium bicarbonate, so we're all familiar with these words. They relieve the underlying cause of some arrhythmias, and they also alter the electrophysiological mechanisms causing arrhythmias. Other agents act on the cardiovascular system by affecting heart muscle or on the autonomic nerves to the heart. Agents such as digitalis, propranolol, etc. Finally, there are drugs that alter the electrophysiological mechanisms causing arrhythmias. So, within the past 5 decades, research on normal cardiac tissues and in the clinical setting on patients with disturbances of rhythm and conduction has brought to light information on the genesis of cardiac arrhythmias as well as the mode of action of antiarrhythmic agents. So, in addition, laboratory tests have been developed to measure blood levels of antiarrhythmic drugs such as phenytoin, lidocaine, other canes, quinidine to help evaluate the pharmacokinetics of these agents. And because of this, it is possible to maintain steady state plasma levels of these drugs, which allows the clinician to use these and other agents more effectively and with greater safety. So, no other clinical intervention has been more effective at reducing mortality and morbidity in coronary care units. So, in terms of the cardiac electrophysiology, the heart depends on the synchronous integration of electrical impulse transmission and myocardial tissue response to carry out its function as a pump. So, we all know that the heart is a pump. So, when the impulse is released from the SA node, and as you would perhaps know, SA means sinoatrial node, and I think for the most part we'll refer to it as SA node. also known as the sinus node. So when the impulse is released from this SA node or pacemaker, excitation of the heart tissue takes place in an orderly manner by a spread of the impulse throughout the specialized automatic fibers in the atria, the AV node, and AV of course means atrioventricular node, and the Purkinje fiber network in the ventricles. So this spreading, and I'm sure you can see the spreading being represented in the image here. This spreading of impulses produces a characteristic ECG, which is an electrocardiographic pattern that can be equated to predictable myocardial cell membrane potentials and sodium and potassium fluxes in and out of the cell. So this is how it works normally. So just to go into that in a little bit more of a detail, we mentioned the ECG, and when you see an ECG, sorry, it will look something like this with your PQRST waves, right? So the first step is that there is atrial depolarization initiated by the pacemaker, which is our SA node, and it causes the P wave seen here. So it starts here, our sinus node that's initiated by here, it has atrial depolarization. Then, so we're following the arrow. Step 2, with atrial depolarization complete, the impulse is delayed at the AV node. So there's a space here between P and Q. And going on to step 3, ventricular depolarization begins at apex. That is, if we're following the arrows here, causing the QRS complex. Atrial repolarization occurs, and then moving on to step 4, ventricular depolarization is therefore complete, and that's that's the space there between S and T. And then step 5, ventricular repolarization begins at apex, causing the T wave. And step 6, ventricular repolarization is now complete here. So these are all the steps, and it's color coded in terms of yellow being depolarization and red being repolarization. So in our introduction, we mentioned automaticity, and we want to explore what it is in a little bit more detail here. So the heart's ability to generate an electrical impulse can occur in any part of conduction system. The SA node has the highest degree of automaticity, so highest rate of electrical discharge, thus is the primary pacemaker, as we mentioned already. Impulse dependent on sodium and calcium into a myocardial cell, and potassium ions moving out of cardiac cells. So essentially this is an electronic transfer of ions across the membrane. So cardiac cell membranes more permeable to sodium, and sodium causes rapid influx of sodium, and calcium follows. So as sodium and calcium move into cells, potassium moves out. Movement of ions changes membrane from resting state from resting state of neutrality to state of electrical buildup. So when electrical energy is discharged, in other words, depolarization occurs, muscle contraction occurs. So the SA and AV nodes, cells in the SA and AV nodes depolarize in response to the entry of calcium ions rather than the entry of sodium ions. And this causes a slower depolarization. And when you have atrial and ventricular cells relying on sodium channels, you have faster depolarization. So if we look at this action potential here, and clearly we're not seeing calcium, but we have sodium ion from inputs, and then there's a threshold that once it passes that particular threshold, then you get sodium entering, right? The channel opens, the sodium channel opens, sodium ions enter, sodium ions close, potassium channel, so when you see close or open, it's related to either the sodium channel or the potassium channel seen here. So we're not seeing the calcium. However, that happens as well. So here at this point, we have the sodium channel closing and the potassium channel opening, and then that causes the potassium to be to move across or move out. So sodium in and potassium out. So that's depolarization and repolarization occurring here, as we see in basically the same diagram but just different words. All right, so the ability of cardiac muscle cell to respond to electrical stimuli is called excitability or irritability. After contraction, sodium and calcium ions return to extracellular space and potassium to intracellular, and muscle relaxation occurs. So when the opposite happens, we have muscle relaxation and the cell prepares for the next electrical stimulus. So following contraction, period of decreased excitability called absolute refractory period, which we saw on this diagram here, absolute refractory period. As ions begin to return to original locations before resting membrane potential is reached, stimulus greater than normal can cause early depolarization, and this period is called the relative refractory period, which we see here. All right, so on this diagram, which is basically the same as the previous, we have a stimulus, then there's a threshold, then you have depolarization and repolarization, you have a refractory period, and go back to the resting state. All right, so another term that we have met is conductivity, and its ability of the cardiac tissue to transmit electrical impulses. So in a similar fashion as we saw, with the SA, from the SA to the internodal tracts, to the atrial contraction, to the AV node. So if we can even follow to the AV node here, bundle of His, then from the AV node to the bundle of His, seen here. Then you have your right and left bundle branches as seen here, and that leads to our Purkinje fibers and ventricular contraction. So that leads us to our first question: what causes the depolarization repolarization effect? That's our first question. And the answer is, well, there is a stimuli, but after that stimuli, there's an influx of sodium and calcium ions into the cardiac cells and an efflux of the potassium ions on the repolarization side, right? So clearly there's a stimulus, and then you have these things happening. All right, so mechanisms of arrhythmias. The current understanding of the electrophysiological mechanisms responsible for the origin and perpetuation of cardiac arrhythmia is caused by altered impulse formation, that is a change in automaticity. So we just define automaticity, and so um, it that is the first cause. You can have a change in automaticity or altered conduction. We just mentioned conductivity. If that is altered, then that is also would have been responsible for the origin or perpetuation of cardiac arrhythmia, or both, right? Acting simultaneously from different locations of the heart. And so the generation of cardiac impulses in the normal heart is usually confined to specialized tissues that spontaneously depolarize and initiate the action potential. So these cells are located in the right atrium and are referred to as the SA node or the pacemaker cells, which we mentioned already. Although the spontaneous electrical depolarization of the SA pacemaker cells is independent of the nervous system, these cells are innervated by both the sympathetic and the parasympathetic fibers, which may cause an increase or decrease of the heart rate, respectively. So, special cells in the normal heart that possess the property of automaticity may influence cardiac rhythm when the normal pacemaker is suppressed, or when pathological changes occur in the myocardium to make these cells the dominant source of cardiac rhythm. And we mentioned our ectopic pacemakers. So, automaticity of subsidiary pacemakers may develop when myocardial cell damage occurs because of a variety of reasons, such as infarction, digitalis toxicity, excessive or high catecholamines, etc. So the development of automaticity in specialized cells, such as that found in special atrial cells, certain AV node cells, bundle his Purkinje fibers, may lead to cardiac arrhythmia. All right, so because production of ectopic impulses is often caused by a defect in the spontaneous phase 4 diastolic depolarization, or the T wave, which we saw earlier, drugs that can suppress this portion of the cardiac stimulation cycle are effective agents for these types of arrhythmias. So I just have, this diagram here to remind us of the T wave. The arrhythmias are also caused by disorders in 1, the conduction of impulses, and 2, changes in the refractory period of the myocardial tissue. So pharmacological intervention is based on these two properties, right? The two properties: conduction of impulses, that's 1, and 2, changes in the refractory period of the myocardial tissue. So the Purkinje fibers branch into a network of interlacing fibers, particularly at their most distant positions. So this creates several pathways in which a unidirectional block in a localized area may establish circular microcellular or macrocellular impulse movement that re-enter the myocardial fibers and create an arrhythmia. So here we have a diagram of what was said right here. So this is the re-entry mechanism of Purkinje fibers. So A is this diagram here is the normal conduction of impulses through the triangular arrangement of cardiac fibers. So notice that, it's going in this direction, right? And for B, which is here, the unidirectional block on left arm of triangular selection allows impulse to re-enter the regional conducting system and recycle. So as we can see here, that's one direction, and normally, it doesn't re-enter the conducting system. However, in this case, as we can see, there is a re-entering occurring, which therefore that re-entering would therefore create an arrhythmia. So that unidirectional block results from either localized myocardial disease or a change in dependence of the tissue to sodium fluxes that causes a longer conduction time and allows the tissue to repolarize to propagate the retrograde impulse. So that leads us to our next question, which says, explain what is happening in the diagram above. And we just saw that. So I'm sure that you can explain this diagram. So the diagram showcases the re-entry mechanism of the Purkinje fibers. Figure A shows the normal conduction of impulses through the triangular arrangement of cardiac fibers, while figure B shows the abnormal one. So it shows the unidirectional block on the left arm of the triangular section, allowing impulse to re-enter the regional conducting system and recycle. All right, so now we're going to go into the drug. So now we should at least have at minimum a basic understanding of what we're talking about here in terms of arrhythmias. So now we're going to look at the classes of antiarrhythmic drugs. Antiarrhythmic drugs can be placed into 4 separate classes based on 1, their mechanism of action, or 2, their pattern of electrophysiological effects produced on heart tissue. So here we have the 4 classes, and as we can see, class 1 is subdivided into A, B, C, 3 other classes, into 3 classes, I should say. We have some lists of drugs. Quinidine we will talk about quite a bit, and there are others in 1A and 1B, lidocaine, etc., 1B, NK9, etc. Class 2, which are our beta-adrenergic blockers such as propranolol. Class 3, we have some examples here, sotalol, etc. Class 4, calcium channel blockers such as verapamil, which we'll talk about a little bit. And as was said here, they are placed in the groups based on their mechanism of action. All right, so for the 3 different subclasses within class 1, for class A, it lengthens refractory period, shortens duration of action potential, and they slow conduction. And for class 2, it slows AV conduction time, suppresses automaticity. And for class 3, they prolongs refractoriness. And class 4 blocks slow inward calcium channel, right? So those are the calcium channel blockers. All right, so despite the well-intentioned use of these agents, most antiarrhythmic drugs have the potential to aggravate the arrhythmia they treat, and that is proarrhythmia. And it develops from an increase in the density of single ectopic beats and is more likely to occur in patients who have a dysfunction in the left ventricle or sustained ventricular tachycardia. So for class 1 antiarrhythmic agents, they're especially pro arrhythmic in myocardial infarction patients. And just to define infarction, it is obstruction of the blood supply to an organ or region of tissue, typically by a thrombus or embolus, causing local death of that tissue. All right, so these are the classes that we mentioned in the table. So 1, we're going to call them membrane depressant drugs. Class 2, we're going to call them beta adrenergic blocking agents. Class 3, repolarization prolongators. And class 4, calcium channel blockers. So for class 1, which is our membrane depressant drugs, there are drugs that have membrane stabilizing properties. That is, they shift membranes to more negative potentials. So drugs in this class act on the fast sodium channels and interfere with the process by which the depolarizing charge is transferred across the membrane. It is assumed that these drugs bind to the sodium channel and block its function, preventing sodium conductance as long as the drug is bound. The prototypical drugs in this class is quinidine, which I said we're going to talk a bit about, and procainamide. All right, so as we mentioned, class 1 antiarrhythmic drugs can be subdivided based on the relative ease with which they dissociate from the sodium ion channel. So for 1C, such as encainide and lorcainide, etc., they are the most potent sodium channel blocking agents of the class 1 antiarrhythmic drugs because they slowly dissociate from the sodium channel, causing a slowing of the conduction time of the impulse through the heart. And for 1B drugs, which include lidocaine, etc., they dissociate rapidly. So for C, they dissociate, that is slow. This is fast. B is fast. They dissociated rapidly from the sodium channels and thus have the lowest potency as sodium channel blockers. They produce little, if any, change in action, potential, duration. And then the third category, which is the 1A, such as quinidine, are drugs that have an intermediate rate of dissociation from the sodium channel. And they lengthen the refractory period of cardiac tissue to cause cessation of arrhythmia. So another question says, list 3 drugs that fall into the 3 categories of class 1 antiarrhythmic drugs. So we always have to be keeping ourselves abreast and knowledgeable about the names of drugs. So clearly we could choose from, the list, but the just chose to use quinidine for 1A, lidocaine for 1B, and NK9 for 1C. All right, so for class 2, which is our beta adrenergic blocking agents, they cause membrane stabilizing or depressant effects on myocardial cells. So their antiarrhythmic properties are considered to be principally the result of inhibition of adrenergic stimulation to the heart. The principal electrophysiological property of these beta blocking agents is reduction of the phase 4 slope of potential sinus or ectopic pacemaker cells such that the heart rate decreases and ectopic tachycardias are either slowed or converted to sinus rhythm. So drugs in this class, and we mentioned some of the names already, cause several different electrophysiological changes on the myocardial tissue, but share one common effect: prolonging the action potential. And this is class 3, which is the repolarization prolongators. And by doing so, they increase the effective refractory period of the membrane action potential without altering the phase of depolarization or the resting membrane potential. So drugs in this class produce their effects by more than one mechanism. So for example, sotalol is a potassium channel blocker and has some beta adrenergic blocking properties. Amiodarone, etc. Drugs are drugs that also prolong the action potential by means that are unclear. Also have sodium channel blocking properties, right? So they share with class 1, and the sotalol shares with class 2. And then our final class is our calcium channel blockers. So although not all calcium channel blockers possess antiarrhythmic activity, some members of this class of antiarrhythmic drugs block the slow inward current of calcium ions during phase 2 of the membrane action potential in cardiac cells. So for example, the prototypical drug in this group, verapamil, it's kind of similar to another name of another drug, verapamil, which we're going to talk about, selectively blocks entry of calcium ions into the myocardial cell. It acts on the slow response fibers found in the sinus node and the AV node, slowing conduction velocity and increasing refractoriness in the AV node. So the first example of drugs that we're going to talk about is quinidine sulfate, and we're just seeing the structure of quinidine here. So quinidine sulfate is a sulfate of an alkaloid obtained from various species of cinchona and their hybrids. It is a dextrorotatory diastereomer of quinine. So this is the structure of quinine, and this is the structure of quinidine. So clearly all of the connectivities are the same. They just have differences in their arrangement at the chiral centers. So the salt crystallizes from water as a dihydrate in the form of fine needle-like white crystals. Quinidine sulfate contains a hydroxymethyl group, that is here, that serves as a link between a quinoline ring, which is here, and a quinacridine moiety, which is up here. The structure contains two basic nitrogens. So we have two nitrogens here, which are basic, of which the quinacridine nitrogen is the stronger base, which are pKa of 10. Quinidine sulfate is bitter and light sensitive. Aqueous solutions are nearly neutral or slightly alkaline. It is soluble to the extent of 1% in water and more highly soluble in alcohol or chloroform. The same drug is a prototype of antiarrhythmic drugs and a class 1A antiarrhythmic agents according to the Vaughan Williams classification, or Vaughan Williams classification. It reduces sodium current by binding the open ion channels, and the decreased sodium entry into the myocardial cell depresses phase 4 diastolic depolarization and shifts the intracellular threshold potential toward 0. So these combined actions diminish the spontaneous frequency of pacemaker tissues, depress the automaticity of ectopic foci, and to a lesser extent reduce impulse formation in the SA node. So this last action results in bradycardia, which is slow heart rate. So during the spike action potential, quinidine sulfate decreases transmembrane permeability to passive influx of sodium, thus slowing the process of phase 0 depolarization, which decreases conduction velocity. So this shown as a prolongation of the QRS complex on electrocardiograms. So quinidine sulfate also prolongs action potential duration, which results in a proportionate increase in the QT interval. So that was a mouthful. All right, so basically this is an example of class 1 antiarrhythmic drugs. Here we have the action potential of myocardial cells in the ventricles, and we have ventricles contract here, atria contract, and we saw the PQRST already. So basically this is the action of class 1 antiarrhythmic drugs such as quinidine. So here, on the ECG, as we mentioned, it's shown as a prolongation of the QRS complex. So this is class 1A, this is class 1B, and this is class 1C, right? So it increases QRS, decreases QT, and 1C increases QRS. All right, so for class 1 antiarrhythmics or continuing with quinidine sulfate, it is used to treat supraventricular and ventricular ectopic arrhythmias, and they are listed there, and I will attach a video that will give you guys an a better understanding of all of these different ventricular ectopic arrhythmia, how they actually look and how they work, and how the drug influences these arrhythmias. All right, so quinidine sulfate is used most frequently as an oral preparation and is occasionally given intramuscularly. It has been absorbed from the GI tract or from the site of intramuscular injection, is bound 80% to serum albumin. The drug is taken up quickly from the bloodstream by body tissues. Consequently, a substantial concentration gradient is established within just a few minutes Onset of action begins within 30 minutes with peak effect attained in 1 to 3 hours. Quinidine is metabolized primarily in the liver by hydroxylation, and a small amount is excreted by the liver. So, because of serious side effects and the advent of more effective oral antiarrhythmic agents, quinidine is now used less, except in selected patients for long term oral antiarrhythmic therapy. All right, so here we have an image with other drugs. So we chose to speak about the prototypical quinidine, but clearly there are others, right? And that is the structure. So your job, as usual, is to look at the structure, compare and contrast, and to see, if there's any differences, similarities between the classes, not the classes, the drugs within the class. All right, so we have another question here. Assign the stereochemistry for positions 8 and 9 for both quinidine and quinine. So this is position 8, the methane carbon here, and the carbon here that's attached to the alcohol is 9. So assign the stereochemistry. So you might want to just pause the video here and go ahead and assign the stereochemistry as R and S for both quinidine and quinine. All right, so for quinine, if you got 8S9R, or for quinidine you got 8R9S, then you would have been correct. And as we saw a couple slides up, that quinidine is the diastereomer of quinine. So if we had figured out one, essentially we could figure out the other one, right? All right, so let's talk a little bit about pH and activity of these class 1. So the action of class 1 local anesthetic type antiarrhythmic agent drugs or agents is pH dependent and may vary with each drug. Antiarrhythmic drugs are wheat bases, as we saw, with most having a pKa value ranges from 7.5 to 9.5. So at physiological pH of 7.4, these bases exist in an equilibrium mixture consisting of both the free base and the cationic form. So I do expect that you understand what that means. Ionizable drugs such as lidocaine have strong electrophysiological effects, is ischemic rather than normal myocardial cells, right? And so this potentiation has been attributed to, in part, to the increase in hydrogen ion concentration within the ischemic areas of the heart. Acidosis increases the proportion of sodium ion channels occupied by the protonated form of the antiarrhythmic agent. Nevertheless, the effect of pH on the antiarrhythmic activity of drugs can be complex, as both the free base and the cationic species have been proposed as the active form of some drugs. So clearly it is not as straightforward as, if the drugs in an acidic or a basic environment, then they will have activity based on that. That is not the case. It's more complex than that. So whether it's a free base or in the cationic form, it has been found that some of them, both of those states, have activity. So the uncharged form of the sodium channel blocker can penetrate directly from the lipid phase of the surrounding cell membrane to block the channel. And small changes in pH can alter these drugs' effectiveness by changing the charged to uncharged molecular ratio in the myocardial cells. So in acidosis, and we did meet this word last semester. External, or not last semester, but sometime previous to this course, acidosis external to the myocardial cell promotes the cationic form clearly, because if you have acid there and it can be protonated, so it would promote the cationic form. So because this species does not partition in the membrane as readily, onset of these drugs' action would be delayed. Furthermore, concentration of these drugs in the membrane would be reduced. Therefore, drugs that act on the channel only in the inactivated or closed state would have a reduced effect in acidotic conditions. So, acidosis may also prolong the effect of these drugs. External acidosis facilitates protonation of receptor bound drugs. So, because only neutral drugs can dissociate from closed channels, recovery is prolonged by acidosis. And the flip side to that is alkalosis, and it tends to hyperpolarize the cell membrane and thereby reduces the effect of antiarrhythmic drugs. So because of this, alkalosis promotes the formation of more of the free base antiarrhythmic agent, increasing the rate of recovery from the block. Alkalosis inducing salts such as sodium lactate have been used to counteract toxicity caused by the antiarrhythmic quinidine. So here we have just one example of a class 2 antiarrhythmic drug, which is propranolol, and that name at least should be familiar. So as usual, you want to look at the structure, you want to look at the functional groups, ensure that you're familiar with them. And these are some examples of class 3 antiarrhythmics. Again, you look at the structures, just compare, contrast, and to see what, if there are any similarities in functional group, etc. And class 4, which verapamil and diltiazem, and I think we'll talk about verapamil a little bit more. So both of them block the slow inward calcium currents, that is voltage sensitive channel in cardiac fiber. So this slows down the AV conduction and the sinus rate. So these drugs are used in controlling atrial and paroxysmal tachycardias, and the structures are below. So verapamil, and that's the the scientific name or the IUPAC name, was introduced in 1962 as a coronary vasodilator and is the prototype of the calcium antagonist used in cardiovascular diseases. It is used in the treatment of angina pectoris, which is a medical term for chest pain or discomfort due to coronary heart disease, arrhythmias from ischemic myocardial syndromes, and supraventricular arrhythmias. I think we've seen ischemia a number of times, and there are different spellings based on American versus British. Is a restriction in blood supply to tissues, causing a shortage of oxygen that is needed for cellular metabolism. to keep tissues alive. So ischemia is generally caused by problems with blood vessels with resultant damage to or function to the tissues. So just to define it, since we have seen it before, we're seeing it again. So those are the things that verapamil treats. All right, so verapamil's major effect is on the slow calcium channel. The result is slowing of the AV conduction and the sinus rate. Verapamil is a synthetic compound. Unlike quinidine, which we saw was, isolated from a cinchona species. It can be separated into its optically active isomers, of which the levorotatory enantiomer is the most potent. It is absorbed rapidly after oral administration. The drug is metabolized quickly and as a result has low bioavailability. The liver is the main site of first pass metabolism, forming several products. The preferential metabolic step involves N-dealkylation. So you can look at the structure and see where that happens, followed by O-demethylation, right? So we can look at the structure and see where that happens, and subsequent conjugation of the product before elimination. So the metabolites have no significant biological activity, and verapamil has an elimination half-life for about 5 hours. Alright, so finally, it is believed that verapamil, like most of the calcium channel blockers, crosses the cell membrane in an uncharged form to gain access to its site of action on the intracellular side of the membrane. Data show a greater affinity for verapamil and other calcium channel blockers to the inactivated site of the channel. So that is basically where we close our chapter on our antiarrhythmic agents. We were able to look at what is arrhythmia, to define it, to define some of the terms, and then we were able to look at the 4 classes of antiarrhythmic agents and what separates them in terms of their mechanism of action. All right, so that leads us to our final question, which is discuss the pH and activity of antiarrhythmic drugs. So this is a question that you will answer in class. So that's basically it for today. Thank you so much for watching and see you next time.